Hello and welcome back. Hope you've been enjoying our session so far. Now we have with us Dr. Sundar. Dr. Sundar is one of the most reputed nephrologists of India and is a wonderful human being. He will be speaking on the subject of choice medicines for post transplant. It is our privilege, Dr. Sundar, to have you on board. Without losing much time, handing the session over to you.
Hi, my name is Dr. Sankaran Sundar. I am the head of International Transplant Services at the Manipal Hospital, Bangalore. And I have been in the transplant field for the last 4 decades, starting from the 1990s at the CMC Vellore in South India. Now, if you look back in the history of transplant, the first transplant was successfully done in Boston in the year 1955. And that was between two identical twins. And because they were identical twins, no immunosuppressive drugs were used. What happens in a transplant is because the kidney comes from some other person, even if they are related, the body considers this kidney as foreign and the body tends to reject. And that is, the body says, I don't want the kidney. And that is prevented by using what we call as immunosuppressive drugs, where drugs suppress the immune system. The basic immune suppressive drugs, which started off way back in the 50s, was plain simple steroids. Along with steroids, azathioprine, or what is sold initially, the original brand by Burroughs Wellcome, was Imuran. Now, this drug, Imuran or azathioprine, changed the concept of transplant and immunosuppression, and people who were not identical twins, that is, even siblings and others could donate, but still the success was not all that great. The real breakthrough, or I would say the cornerstone of immunosuppressive therapy, the change which occurred, the magic drug, I would say, was a drug called cyclosporin. This drug in the early 80s changed the entire scenario of transplantation. I was very fortunate to be in the field of transplant in what I call the BC era, or before cyclosporin era, and the AC era, or the after cyclosporin era. In the before cyclosporin era, if you do 100 transplants, at the end of 1 year, only about 50 would be actually doing well. About 50 would have rejected. The rejection rate was very high. And once we started using cyclosporin, the whole scenario changed. When you do 100 transplants, 90 or 95 would do very well. There would not be much rejection. So cyclosporin changed the entire gamut of transplant scenario. It's called a CNI. And because of the side effects of cyclosporin, the earlier days, cyclosporin was used in very high dose, and the dose was so high the kidney would get toxicity. The drug itself was damage the kidney, and there could be problems. Slowly, we understood how to use cyclosporin, but the most important thing which came was drug level monitoring, what we call as therapeutic drug level monitoring, or TDM. So because we could monitor drug levels, we could adjust the dose of cyclosporin and we could really give the correct dose. And this changed the entire scenario of transplantation. Along with cyclosporin, we were using what is called triple drug regime: cyclosporin, azathioprine, and prednisolone. This is the common practice in my practice from the 80s to nearly 1995, I would say 15 years. Then the drug came called mycophenolate mofetil, or MMF. Now, this drug, originally from Roche company, was sold as Cellcept. Cyclosporin, the original brand, was called Sandimune. And again, that cyclosporin had to be given in a specific way. We cannot use metal spoons. It had to mix with orange juice or milk and given. And later on, this Novartis company, earlier called Sandoz, changed the formulation to cyclosporin, which is called Neurol, into capsule form, which could be taken very easily. So that was another change. Cyclosporin Neurol, which could be swallowed easily. Then the start or addition of a drug called mycophenolate, or MMF, which was replacing azathioprine. Then came in the drug called tacrolimus, or FK506. Originally, it was actually from the company called Fujisama, a Japanese invention, I would say. Because of this drug, FK506, the brand name was Prograf. Prograf, the original brand name, even though it's available by the company Fujisama, which has now become Astellas. And this drug, interestingly, if you look at cyclosporin, initial days when cyclosporin was used by us, it was not available in India in the open market. We had to smuggle cyclosporin. In fact, black market was making a lot of money, and doctors and friends who were coming from other countries were getting cyclosporin. It was not available till the Sandoz company, now called Novartis, brought it officially. But interestingly, if you look at tacrolimus, the patent actually for tacrolimus ended, and a lot of Indian companies started making tacrolimus in their own brand name. So this is a very unique situation only in India, where the generic drugs came in much ahead of the original brand. The original brand from Astellas, or which we use, Prograf, came much later, nearly 5-10 years after the Indian company started making the drug. Now, if you look at the Indian company which pioneered the use of tacrolimus, it was a company called Panacea, which brought in Pangraph, and then a lot of other companies came in. You got Imcure, Wingraph, you got from Alnish company, Biomus. So many brands are there. In fact, the Sandoz company, which is now also part of Novartis, it makes generic drugs. It makes a drug called Taxant, which is a generic of the tacrolimus made in India by Sandoz company. So the question now is, so commonly now what we do is, now the current practice, or we call the gold standard practice, which is proved now by a study called the Symphony trial. This is a trial actually promoted by Roche company to study mycophenolate. And they found out the gold standard of the Symphony trial was low-dose tacrolimus, mycophenolate, and steroids. So these three drugs is the gold standard of transplant immunosuppression. Now, there are other drugs which have come into the market. One is called sirolimus, which is actually a drug discovered by Indian scientists, whom I had a chance of meeting him quite a few times. He passed away later on. Now, if you look at, there are specific indications. I have used sirolimus, everolimus in certain cases. It is less nephrotoxic, but it has also got a lot of other side effects, starting from proteinuria to high lipids, or the cholesterol levels go up, anemia, and it has also got other lung issues. So it is not easy to use, but there are certain indications where it is very useful. A transplant patient having cancer, as well as something called Kaposis sarcoma, a skin cancer, where you use, instead of tacrolimus, we use everolimus or sirolimus, and the Kaposis sarcoma can disappear. So there are certain indications, numbers are less. Now, looking at the other drugs which we had, there are many other drugs coming into the market, which is now where we don't need to use cyclosporin or tacrolimus. There is something called belatacept, which is an injection given regularly every week. It's still not very popular in India. It is expensive. Now, when you do a transplantation, the main problem with transplantation is rejection. So the kidney transplant can be lost. What we call as graft failure is due to rejection. The other problem is because of the drugs. Because we give immunosuppressive drugs, the patient is prone for infection. And because we use drugs apart from steroids, the other complication of long-term immunosuppression, starting from a person who's had transplant, is vulnerable for more infection, especially during the COVID era. We have seen transplant recipients actually dying because of COVID. When you start doing transplantation, earlier the dose of drugs used is little high dose. In fact, steroids, I started with 20 milligrams in the first week, and by about 3 to 4 months, they come down to 5 milligrams a day. There are people use without steroids, called steroid-free transplantation. I'm still not convinced that's the way to go in India, because I still feel a small dose of steroid is useful. But there are specific indications for not using steroids, especially in children. It requires a different protocol. Now, when you do transplantation, the initial few days is very vital. That is where the body's immune system is fighting. So what we do is, the initial few days, we could use something called induction therapy. The induction therapy commonly used are what is called as basiliximab, which is 2 doses given on the table and on the 4th day. Then there is something called thymoglobulin. This is a drug which is commonly used. There are 2-3 companies which are making thymoglobulin, which we may give on the table for a few days, and that could prevent rejection. In fact, if there is a rejection, that one of the ways we treat the rejection is using high dose of steroids, injectable steroids, and then we may do a kidney biopsy Based on the biopsy, we may use thymoglobulin and we may use other drugs like rituximab and plasmapheresis and all. Now, I come to another important topic. The problem with transplant is the cost. A person who's had transplant, tacrolimus, mycophenolate, and prednisolone. How do we reduce the cost of therapy? One of the ways, if you use the original brand, which is called the innovator brand, that is the companies which discovered the drug. If you use those brands, they are mostly imported and they are expensive. So what we tend to do is we use Indian brands. Indian pharma companies are doing good job, whatever maybe the media and TV tell you. They have been doing good job, and the doctors of tacrolimus, starting from Pangraph or Wingraph, Biomass, Taxan, you name it, goes on. The list is enormous. Same way with mycophenolate. But majority of these drugs, you must understand, the bulk drug comes from 2 or 3 companies only. And then the other smaller, I want the smaller companies, the other companies get these bulk drugs and then they make it into tablets or capsules and then distribute it. The question now commonly asked by most patients is, should I use the innovator brand, which is the original brand, or should I use the generic brand? Now, it is your transplant team which decides. If I am given a choice, my own family member, if I am given a choice, and if I have enough money, I would use the original brand because it's time tested, trials are there. Now, having said that, the generic is equally good, but our own experience, in fact, my colleague Dr. Vijay Kher has done some work and his own advice and our own Indian Society Transplant guidelines, we suggest that when you use a generic brand, please do not change one generic to another. Suppose, for example, you are on Pangraph, you continue to take Pangraph forever. Don't shift. One day you take Pangraph, next day Wingraph, third day Taxan. Don't do that. Because even though the molecule is same, the absorption and the metabolism, in our opinion, changes. So what I suggest to my patient is, if you want to change either from the original brand to a generic or from a generic to another generic, it's like a new transplantation for the first month. Under the supervision of a nephrologist, do kidney function tests once a week or twice a week, do regular drug level monitoring, and then adjust the dosage. So that is key. Now, the question now in COVID, I know a patient from Assam, he had difficulty in getting drugs. Every day he was on different brand of generic tacrolimus. Now, that's okay. What I would say is ideal situation. But you must understand, everything is not ideal in life. Perfection is the enemy of good. So you must look at good things in the overall picture. So what do I suggest? If you don't get any brand, take some brand of tacrolimus. It is better to take it than not take any brand. The question now is, once you take that brand, it is better that you check your creatinine, kidney function, and blood, drug levels if possible under the supervision of your transplant team. So the short answer to this question is, should I take generic or should I take innovator brand? The answer is your transplant team. Please have trust in your transplant team and they work with you, because your body metabolism varies. Your doctor, your team knows the best. My suggestion is, ideal would be to follow the transplant team's advice and keep monitoring the drug levels, because we are fortunate by doing a drug level. Again, drug level also there is a problem. Each lab to lab, there is variation. My own suggestion is, please have trust in a good lab. Identify one good lab which can give you the correct kidney function and the correct TAC levels, because that way there is variation is less. If you do the TAC level in one lab and do it in another lab, the way it's being done is different, the levels may vary. So finally, it is very important that for a transplant, have trust in your transplant team, and I'm sure everything will go on well. Thank you. God bless.